Thank you very much. It's a real privilege to be here. So thank you for inviting me to talk today about the impact of COVID on maternity services. Suzanne's already introduced Birthrights as a charity. We aim to improve maternity care through a focus on human rights. And I really like this quote because I think it really sums up what we're all about at Birthrights. It says, "I do not care what kind of birth you have, a home birth, scheduled caesarean, epidural hospital birth, or if you birth alone in the woods next to baby deer. I care that you had options, that you were supported in your choices, and that you were respected." So that quote is from an American birth activist called January Harsh, but it really illustrates the fact that at Birthrights we don't have any particular agenda about how people should give birth. We're all about supporting women and birthing people to find what's right for them and to be supported in those choices. Oh, the slide's gone a bit funny. Okay, so just to tell you a bit about the kind of activities that we do at Birthrights, we have an advice line, as Suzanne mentioned, so women and birthing people are welcome to contact us by email about any inquiries they have about the care that they're receiving. We also hear from healthcare professionals. We're very happy to answer questions from healthcare professionals as well. We also offer training to healthcare professionals, so we run courses at trusts, and we also train groups of peer supporters so they're aware of how human rights applies to maternity care. And then we combine what we learn from the advice service and from what we learn from training healthcare professionals and working closely with them, and that informs all our campaigns, research and policy work. Suzanne referred earlier to the fact that one of our flagship pieces of work at the moment is an inquiry into racial injustice. I know many of you will be aware that black women are 4 times more likely to die around the time of childbirth than white women. Asian women are twice as likely to die, and women from a mixed ethnic background are 3 times more likely to die than white women. The inquiry really seeks to centre the experience of black and brown women. Leigh have been absolutely brilliant in terms of their support for that inquiry. I know that many of the solicitors who are working on the Secretariat are here today, so it's great to see them, but we're really grateful for that support that has enabled that to go ahead. But today I'm going to take you back to a time last year when all we did as a charity was focus on COVID. Like many organisations and particularly health services, overnight we really had to pivot what we were working on to focus on what was happening with the pandemic. We saw inquiries to our advice line go up by around over 400% initially in March. So very quickly had to bring in lots of extra resource for our advice service. We also spent a lot of time working with other charities through the But Not Maternity Alliance, and working with NHS England and with the Royal Colleges to feed back to them what we were hearing from women, and to influence changes in guidance, particularly on things like wearing face masks in labour, triaging of women who were declining testing a bit later on, and the fact that unassisted birth or free birth was increasing rapidly at the start of the pandemic last year. We also engaged with individual hospital trusts where we felt their policies might be disproportionate, or they hadn't thought properly about the impact of changes to their services on women and families. So our message throughout the pandemic was that human rights always matter. Even in a pandemic, there are obviously absolute rights that everybody is always entitled to. So everybody should always be treated with dignity and respect. They are entitled to have their basic needs met, so with food and drink and physical support. They should have access to pain relief. Those things that should always be in place. There are also qualified rights under Article 8 to choose the circumstances of your birth. And these can, of course, be restricted if there's a good reason, and the pandemic is perhaps the strongest reason we've seen in a while for restricting choices around where people give birth and who is with them. But the key thing is that those changes to services are proportionate, and that was really our focus for most of the pandemic, on whether trusts were making decisions that took into account the impact on women and families. So one of the things we did was to develop a tool that would help services to make these decisions. It's obviously a new situation for organisations facing conditions that they'd never seen before, and we really wanted to help them think through the consequences of their actions. So what we were encouraging them to do was take a look at what would it take to keep the service as it is? What are the pressures on the service and how can they be managed? And really important to involve service users in those discussions. The NHS England guidance was clear that maternity voice partnerships should be involved in those decisions, and that trusts should also talk to their neighbours about how they could collaborate, for example, to keep home birth services operating if one trust was struggling. Was it possible to work together to put in place a solution that meant that people could still have access to those choices? In some of those cases, it was not possible to keep services running as they were, and changes to services did have to be made. But the important thing was that a trust looked at each option for changing the service and assessed how far does it help with COVID, what's the evidence for that, but also how far does it have an impact on the people who are using the service, and weighing those two things up, particularly looking at what the unforeseen circumstances might be for marginalised groups or people who found it more difficult to access the service. Then the trust would need to take a decision about what the most proportionate option was, but what we were urging trusts to think about was the fact that the most proportionate option might not be the option that has the greatest effect on reducing the spread of COVID. Obviously, maternity services could have taken the view that they just keep out all partners from maternity services, but from our point of view, not having a partner present during labour and birth was never going to be a proportionate option. So it's looking at what are the options and what's the most proportionate option. And then once that policy is in place, making sure that it's reviewed regularly, making sure that you're clear about why that policy has been put in place and what it would take to change the circumstances and to review that decision, but also to consider individual exceptions. So Harriet Harman had a lot to do with the Equality Act, which is a piece of legislation we rely on strongly in our work. And we heard a lot of trusts saying to us, well, I can't make an exception for you because that wouldn't be fair on everybody else. But obviously that is not the definition of fairness under the law. We were reminding trusts that they needed to make reasonable adjustments for women who had particular physical or mental health requirements, and that's what the law requires even in a pandemic. So, did we have trusts who made rights-respecting decisions during the pandemic? I think it's fair to say that there was quite a lot of variability in decision-making, but an overwhelming focus on controlling COVID, and I think this is something that we can learn lessons from. It's natural that was the focus of attention, but all the evidence about other things that are important to women giving birth went out of the window in some places. So these were some of the headlines we were seeing during the pandemic regarding how pregnant women were experiencing their care. I should say that there are a lot of women who receive very good care, but there was also a lot of women who felt abandoned and felt that they were alone during their hospital experience, particularly during the giving birth and the postnatal period. There were consequences of the changes to policies that weren't necessarily foreseen. For example, a lot of women had to go to triage on their own, and they knew that they didn't really want to say yes to a vaginal examination, but they knew if they did say yes and they were deemed to be far enough along in labour, then their partner would be able to join them. So, and it was all that additional pressure to say yes to things that people might not have said yes to otherwise. As I mentioned earlier, we also saw a huge increase in the rise of unassisted birth, and a big increase in the interest in home birth, given that people were being given the message that they should stay at home. It's important to mention as well the impact on healthcare professionals, many of whom suffered moral injury of having to to police these restrictions. I spoke to a midwife a couple of weeks ago who was telling me about how she had to tell a father in the car park that his baby had just died, and the impact of that experience on her is something that she'll never forget either. So these are the categories of human rights issues that we saw in maternity care during the pandemic. Some of the issues that we saw may reach the threshold of inhuman and degrading treatment, for example, giving birth alone or being asked to give birth with a mask on. And things like that carried on for quite a long time. A survey by Pregnant and Screwed in November 2020, so quite a way into the pandemic, showed that 7% of those surveyed gave birth alone, which is concerning. There was also a category of human rights issues that were brought around the visiting restrictions that were put into place. I think miscarriage care and people attending scans alone is still an ongoing issue in some cases. Again, we had an advice inquiry this week from a woman who'd gone through IVF, had got pregnant against all the odds and after a really difficult time. And then at her first scan was told that her baby had sadly died. She required an operation to resolve the pregnancy, but she had to wait for hours for that operation without anybody to support her. And that's something that's very recent. So we had issues over partners being able to attend scans in person, and also issues about them being allowed to join by video call. And we actually published some legal advice that we commissioned, which was a reminder to trust that they need to think carefully about why they're saying no. They have to have a good reason to say no. Having somebody on a video call, if they can't be present in person, seems like a reasonable thing to ask, and that we saw more of that as the pandemic went on. There was also restrictions around inductions, partners being present for that, restrictions about postnatal visiting, and restrictions around neonatal visiting, parents visiting babies in the neonatal unit as well. There was also a group of human rights issues around limited choice. So a lot of trusts suspended home birth or midwifery-led services, particularly at the beginning of the pandemic. And some trusts even went down the route of starting to refuse requests for C-sections where they hadn't done that before. And we also had a lot of inquiries about the suspended use of birth pools. Birth pools, obviously, a very tried and tested means of pain relief, and not a lot of evidence around them being a big transmitter of COVID, but many trusts took a kind of risk-averse approach on that and reduced the use of water birth. These are some quotes from the families that we had contact with, which show some of the impact that these changes to services and restrictions had. So, husband left on the day she was born, missed all of her being ill and was not allowed to see her until we were sent home. Recovering from surgery and looking after a baby was extremely difficult, and staff did not want to come into our rooms unless they had to, having to put on their PPE. So when the door closed, I felt alone. We heard quite a lot of stories like that, people not being able to reach their call bell, or experiencing nervousness of staff from coming too near them, even though they were struggling to look after a baby on their own. I had a very fast labour and my husband missed the birth. Although the midwife was lovely, it's something I'm having trouble processing. One of the things we also did as a charity was try to help trusts to quantify the mental health impact that the changes they were making were having on women. So we worked with a health economist called Rachel Hunter, who's based at UCL, just down the road. And she looked at the likely impact of COVID on the mental health of women who are pregnant or had just had a baby. And she estimated, looking at the evidence, that there was a 3 to 5 times increase in perinatal depression and anxiety due to COVID. Now, not all of that is down to maternity services. A lot will have been down to COVID itself and the impact of lockdowns, the impact of not having contact with friends and families. But she estimated that there's a 10.6 billion increase in the cost of depression due to COVID, and a 6.9 billion increase in the cost of anxiety due to COVID. So for your average trust, with just over 3,000 births, that would be 12.6 million per trust. But I think the really important point to take away from this piece of work is that maternity services can reduce that. Rachel estimated that that could be reduced by 5 million, or nearly half, depending on what visiting restrictions were in place. So there is a choice there, and I think it's important for trusts and maternity providers to be aware of the impact, really huge impact on mental health that they can have, depending on what visiting restrictions and policies they have in place. I want to emphasise that there were some really positive actions taken during the pandemic in maternity services. We did see some trusts who really went the extra mile to make sure that they were providing person-centred care. So this was particularly the case where trusts already had continuity of care in place. We found that trusts that had that relationship with women, knew their women really well, could maintain that relationship, and that mitigated some of the effects of communications from trusts as a whole being a bit variable, for example. We found some trusts who really increased their home birth provision and midwife-led provision in response to the fact that that's what women were asking for and what they wanted, rather than clamping down and bringing everything back onto the hospital site. We saw innovative measures being put in place. Some trusts put private ambulance services in place, for example, or agreed a protocol with their local ambulance service whereby less urgent transfers would be made by car or taxi rather than by ambulance, to reduce the pressure but ensure that home births could still go ahead. And some trusts, like South Warwickshire, for example, made sure they provided food to partners on the ward. One of the issues was that partners were kind of wandering round trying to go to different places to get food or to get supplies for their partner, but actually what the hospital needed them to do was to stay in one place. So South Warwickshire thought about, how can we do this? Well, if we provide them food where they are, even though that's not what we normally do, that's going to solve the problem. So there were some really good examples of trusts taking the initiative and really thinking through how they could tackle some of the pressures they were facing. But there are also some trusts where we felt the only option was to go for legal action, and that was something that we never undertake lightly, especially in a pandemic when trusts were already under pressure. But some of the policies we were seeing just really were quite distressing, and Leigh supported us with many of those cases. So one of the cases we took to legal action was a unit where the parents had a premature baby who was in the neonatal unit, and another parent in the neonatal unit tested positive for COVID, and the parents were told that they therefore couldn't see their daughter for 10 days, even though they had both tested negative and the baby had tested negative. So Leigh wrote a judicial review pre-action letter to the trust. There was a number of backwards and forwards with the legal letters, and eventually the parents were allowed to stay with their daughter in a private room a couple of days before the end of the 10-day period, before they were able to take her home. So again, we felt the legal action helped put pressure on the trust to think about the consequences of their actions. This first article relates to a woman in a London hospital who tested positive for COVID a couple of days before her planned caesarean. And she was told because she was COVID positive, she wasn't able to have either her partner or anybody else that she knew in theatre with her for her birth. So she was dropped off at the door of the hospital by her partner, and she didn't see him again until 4 days later. So he didn't see the birth, he couldn't go and visit her or see his newborn baby for 4 days. Again, we wrote to the trust about that policy, and they changed it a few days later, thankfully. Another more recent case was a board in Wales who put in place a policy whereby partners could only stay for 30 minutes if their woman had had a caesarean, and for an hour if they'd had a vaginal birth, and then that was it for postnatal visiting. So again, Leigh wrote a judicial review pre-action letter, and the health board changed its policy a few days later to allow visiting by appointment. So overall, some lessons from COVID in terms of how it's impacted on maternity services. I think what we've seen is a lack of ability for trust to predict the consequences of their actions. So we've seen a number of unintended consequences which have actually been picked up more recently by HSIB reports, for example. So we know that when restrictions have been put in place, that women have delayed going into hospital or delayed seeking help, or discharged themselves early, and that's had an impact on their care. We know of a woman, for example, who declined to go in for induction, whose baby sadly died because she didn't want to go in on her own. So I think there's some really important lessons that we can learn from the measures that were put in place to try and control COVID, but all of the consequences that those restrictions had. And trusts need a better way of predicting that. The HSIB report on intrapartum stillbirths that was published a couple of weeks ago pointed out that in other industries, they have ways of analysing the impact that changes are going to have and looking at that prospectively, but that wasn't the case in healthcare, and this was having a safety impact. I think COVID also highlighted perhaps a weakness in the structure in the NHS, and that decisions were very much delegated to individual trusts. In some areas, there was a lack of transparency over how decisions were being taken. It wasn't clear who was being involved, what evidence was being looked at. There was a lack of service user involvement in some areas, although that was better in some places. And in some areas, the communication of those decisions with service users was very poor. And again, that led to tensions and problems of its own. So we heard of a service, for example, who changed its policy about partners attending scans, but a number of people hadn't been told about that. So the partner was attending and then perhaps getting a bit aggressive, or people getting upset because their expectation was that the partner would be able to go into the scan, but the decision to change that policy hadn't been well communicated. It also meant that we felt there was no means of appealing disproportionate policies, although we worked closely with NHS England to make sure guidance was in place. If local trusts weren't following that guidance, there didn't seem to be a mechanism for flagging that up or appealing or escalating the concerns, which is why in some cases we had to resort to legal action. In terms of visiting restrictions, important to note there are some restrictions that still remain, particularly restrictions on postnatal visiting, which is only at 2 hours in some places, and in fact in one health board in Wales and one trust in Northern Ireland is still no postnatal visiting at all. Really important that that doesn't become the norm. But on the positive side, we're really pleased that NHS England has made clear that it won't be making any changes to its guidance, and it's clear that partners are not visitors and should be an essential part of maternity services. Finally, I just wanted to flag up that although I think for many of us, just being here today, it feels like life is getting back to normal, but one of our concerns as a charity is that perhaps for maternity services, the crisis is only just beginning. We've seen an exodus of 300 midwives over the last couple of months, just over the summer. Staffing levels in maternity services were already at worrying levels. It now feels like people have had enough. They are burnt out. They are retiring if they are, at the age to do that. They are leaving for other professions if they hung in there during the pandemic. And we think that it's really important. There's a laser sharp focus now on retention. Otherwise, issues in maternity services are only going to get worse rather than better. I hope that's a bit of an overview of COVID on maternity services, but thank you very much for listening, and happy to take questions later. Thank you.